You from potentially around the globe. My name is Todd Paulette. I am the National Sales Manager in the United States for Mermaid Medical. And on behalf of Mermaid and Canyon Medical, MaxPlate Microwave Technology, I want to welcome you to this edition of the International Microwave Ablation Academy webinar. Tonight, we'll hear from Dr. Alireza Falahati about his experience with thyroid ablation. He'll discuss patient selection, procedural considerations, how his practice has evolved over the times, and how MaxPlate and ThyTip fit into his workflow. Dr. Falahati is the medical director and CEO of the Utah Endocrinology Associates, founder and director of Salt Lake City RFA, and has been a practicing endocrinologist in Utah for an excess of 25 years. He went to medical school at the University of Vienna in Austria, did his residency at Hennepin County Medical Center in Minneapolis, Minnesota, and conducted and completed his endocrinology and metabolism fellowship at the Mayo Clinic in Rochester, Minnesota. Dr. Falahati is an experienced physician who exercises a patient-centric, multimodality approach to everything he does. He's extremely well-versed in all currently available ablation technologies, having performed in excess of 540 cases with RFA, microwave, and impulse for thyroid tumors, both benign and malignant. Just for housekeeping, your chat function should be enabled if you would like to submit questions into the chat. All questions will be managed at the end of Dr. Falahati's presentation. We sincerely encourage you to put questions in there. We would love to explain a little bit further if you have questions. And at this point, I will turn the program over to Dr. Falahati. And thank you, Dr. Falahati, for being here and for sharing your experience with us. And at this
Thank
point, you can go ahead and share your screen. You should have full access, Dr. Falahati.
Absolutely.
There
Thank
you
you very much, Todd. I really appreciate the introduction and the opportunity to talk to everyone here about a topic that is very near and dear to my heart, and that is thyroid nodule ablation, especially with the amazing experience I have had with Canyon Medical's microwave ablation system, which really, in my opinion, has been a game changer for me. So without any further ado, I would like to start. And again, I can continue probably talking in between. Even when we look I share my screen and we start looking at some slides. Give me 1 minute. Okay. So my screen is ready to go, and here we are. Okay. All right. And I am, are you able to see my screen right now?
Yes, sir. You are sharing. We can see the screen. If you want to go
Perfect.
in presentation mode, that'll make it nice and big for everybody.
Absolutely. Yes. Give me 1 second, and here we go.
Beautiful.
Okay. So the ThyTip 18 gauge has been, in my opinion, a game changer. And the first time I was introduced to the system was approximately 2 years ago, when up until that time, my only experience was with the other microwave technologies and systems, where I was having some issues with the size of the needle that came only in 16 and 17 gauge, and the lack of sharpness or the dullness of those probes, and how challenging from an operator standpoint was to perform the thyroid nodule ablation the way I would like to do it. So I was leaning up until that time towards radio frequency ablation, and because the probes were sharp, they were thinner, they came in 18 gauge at the time, and I did not need to worry about cutting or piercing the skin first to create a channel to pass the probe through. And when I saw the uh, Canyon Medical's system first time, I was really impressed by how well this antenna was built and how advanced their system was and how user friendly it was. So I finally was able to get my hands on some of those antennas and try them, and they were truly a pleasure to work with because one, it was very easy to use, so extremely user friendly, and two, highly efficient, and I was able to really maneuver around with my antenna and ablate the nodule the way I would like to. So then, of course, I try to keep a fair balance between radio frequency ablation and microwave. And with all these technologies, I have worked with pretty much every company that is available in US market, both in terms of radio frequency and then microwave, as well as also as of late in about 30 patients with N-pulse or nanosecond pulse field ablation. So without any further ado, I'm going to go through the slides also to be respectful of your time. And then at the end, I would be happy to answer any questions and also add any additional information you need. So this is me, and the image on the left is just an image of my clinic in Salt Lake City, Utah. And the big question is, of course, thyroid ablation in the United States. Uh, as you know, U.S. market has been kind of lagging behind many other countries or most countries when it comes to radio frequency ablation and or microwave ablation and the whole ablative technology, while Asian countries such as China and South Korea have been using these technologies for the past 20 plus years, and also European countries such as Italy have been on the forefront of it, and South American countries, Brazil, highly advanced. United States eventually started adopting thyroid nodule ablation, starting with a radio frequency ablation, because that was the first one that was offered to the US physicians who were in thyroid or interested in thyroid ablation. They were mostly head and neck surgeons and interventional radiologists. And it slowly gained traction over time. One issue, of course, was the reimbursement issue, and that was very challenging because at the time when I started, we had to just find patients who are willing to pay self-pay and not run it through the insurance because no insurance would cover it. Now, things have changed since January of 2025. There is a CPT code for thyroid nodule ablation, and even that code and the use of it has evolved, and its acceptance by insurances also has changed. And I would like to talk about it at the end of my presentation. So, in terms of thyroid ablation in the United States, um, of course, it was initially patient driven. Now, that has over time um, evolved again into um, patients and providers literally pushing for um, radio or asking specifically for ways to avoid the conventional methods of uh, surgery or observation and dealing with the symptoms on a daily basis, and they all ask for specifically for thyroid ablation. And also, what really makes me happy is now some primary care providers in my community, at least, they are starting to send patients to us with the request for thyroid nodule ablation. So we are going to talk about these uh, transitions and where we are at right now, and then also in terms of selection, technique, and technology at the end when after talking about some other aspects of thyroid nodule ablation. Um, the challenges are when we are looking for treating patients, identifying the suitable or ideal patient. Now, who is an ideal patient? That is typically a patient who has been diagnosed with a thyroid nodule. The nodule needs to either cause symptoms or be visible and cause some psychological distress to the patient. Or when you do the ultrasound, you can clearly see the nodule is large enough to cause some mass effect and shift the trachea to the opposite side, and then the carotid artery also to the lateral side. And you clearly see that those structures are making an arch around the nodule. Even if the patient doesn't have symptoms, when you see that, that already is potentially a risk to the patient and needs to be addressed. So that would be the ultrasound evaluation. We look at the nodule, but also we look at the adjacent structures and see what kind of impact does that nodule have on those structures. And of course, a good history and evaluation of patient's symptoms. Sometimes at first, when you ask the patient, do you have any symptoms of pressure or discomfort in your neck? They say no. And then when you dig deeper and ask them specific questions about, do you have you noticed that recently you choke more frequently on your food, or you need to drink water to push it down, or you feel some resistance, or when you lay down at night, you feel more pressure and you have to find a comfortable position to sleep in? And then suddenly the patient realizes, well, actually, I have these symptoms. So once we identify the right patient and we look at it by ultrasound, the next step is, of course, to confirm that the nodule is benign, and that would be, of course, a biopsy. Now, if the nodule appears very benign, and yet because of its size and the fact that we are planning on doing an ablative procedure on that nodule, we are required to do a biopsy. Then one biopsy would be probably enough. But if you are dealing with a nodule that has higher TIRADS criteria or TIRADS score, then you may want to consider doing two biopsies and confirm its benign nature twice before you comfortably can move forward and do the ablative procedure. Now, a few other things that while you are doing the ultrasound and evaluating the nodule, you need to keep in mind is always, always, always look at the volume of the nodule. American Thyroid Association has a site, one page, where you can literally type in the measurements of the nodule and it gives you the volume. If you have multiple measurements over time, you can put all of them in and it tells you changes over time and what percent volume change we are dealing with. And then, of course, as we are also looking at the nodule by ultrasound, we need to mentally prepare ourselves. We need to know where the nodule is located at. Is it very close to the surface and away in the anterior portion of the thyroid lobe, um, which would be a safer location away from recurrent laryngeal nerve, vagal nerve, carotid artery, or the trachea. Then it would be an easier procedure and requires less preparation. But if you're talking about a nodule that is deeper located, closer to the danger triangle on either side, or all the way in the back where you feel like, I really need to secure this nodule, then you mentally prepare yourself to do the so-called hydrodissection. And again, if you have had a formal training in radio frequency ablation or microwave ablation, you are very familiar with this term and you know how to do it. And if not, you will learn it at your first training. But we need to map it out and know exactly where the nodule is and how we want to approach it. And again, how the way we approach the thyroid nodules is always transismic. We try not to do the lateral approach because lateral approach significantly increases the risk of damage to the recurrent laryngeal nerve and damage to the danger triangle. And once you have mapped it out and mentally prepared yourself, then I think you already automatically in your head have that safe ablation procedure figured out. And also, you will realize that as time goes by, and the more ablations you do, the easier you will find it to kind of plan and come up with a strategy that really protects the patient and prevents complications. As far as the key criteria for an ideal antenna is concerned, you want the probe or antenna that you're using to be really visible, to be easy to handle in terms of ergonomics and um, details of like the handle, the design of it, and how you can hold it without it slipping out of your hand. Some companies have antennas or probes that are teeny, have a very small handle, and some are just designed in a way where you can't even hold them and they keep sliding out of your hand. So those are little technicalities, but that make your life really so much easier if they are designed well. And in terms of additional technologies or safety measures or controls that help you deliver the energy in a more stable and steady way, that is really essential and important. When you look at different companies, different systems, and ideally, you want an antenna that is as sharp as it can be, as thin as it can be, and therefore it will be less invasive and easier to maneuver. If your needle or antenna or is very dull, then you not only have to pass it through the skin with some struggle, but also you have to penetrate the capsule of the thyroid and then the nodule, and every one of them becomes a challenge if you are not having a sharp antenna. Also, in terms of power, again, you want at the same time, I mean, microwave devices are known for their power, but to maintain the sharpness and the uh, basically high gauge or thin caliber, and at the same time to be powerful, that is the challenge. And this is what really impresses me with Canyon Medical's technology and system. So max plate or tie-tip system is really, in terms of precision, as far as placement is concerned, and the steadiness of the amount of power that goes into the tissue, as well as, of course, the power and also visibility on ultrasound, really important, but also ability to maneuver it around, it really is ideal and very, very impressive. Now, in terms of power strategy, again, as a general rule, if you're going with the 18 gauge probe, when you are close to the surface, close to the capsule on either end, you try to go with a lower amount of energy, maybe around 25 watts, around peripheral zones. And then when you get to the center, you want to crank it up and go with 30 or 35. It's very easy to set up, so it's not very complicated. And a really thing I love um, about Canyon Medical is literally the fact that it's very easy to set up, and also its cooling system and the generator are all in one and not two separate units that you need to worry about. Um, and also, it's really, once you start, it is fully capable of maintaining a steady flow of power, and the procedure is very smooth without any interruption or any other issues. So again, really advanced technology. I think that's the best way to put it. So microwave versus RFA. So in terms of energy delivery, electrical currents versus electromagnetic energy, and then other factors that will be brought up when you talk to the RFA people versus microwave teams is impedance, hydration, vascularization, heat sink effect. So let's talk about them. Impedance is the indicator of stiffness of the tissue. That's something that you hear very often when you talk to radiofrequency ablation companies. That is one method of safety measure for by their companies and designers, where you really the machine senses the stiffness of the tissue, and as the impedance goes above a certain limit, they have some certain safety measures to avoid charring and burning of the tissue by reducing the power. So if you keep it in one place for too long, the machine cuts back on the power, and they claim to be a really advantage over microwave. In my opinion, it is not. It just limits you significantly. You are in the middle of a procedure, you have your strategy in your head, and you're ready to go, and you fire, and the system gives you, instead of 30 watts, maybe 5 or 4 watts, because it senses that the tissue somehow is too stiff and doesn't let you ablate that area, even though you have barely been working in that area. So, lots of errors that can happen in that moment because of the misreading of the impedance, and then overriding your decision to fire or to go with a higher power. Another area that is very kind of area of debate is vascularization or hydration status of the tissue. Let's say you have a tissue that is a complex cystic solid tissue and has multiple smaller cysts throughout the tissue, um, or a tissue that is highly vascular. In my opinion, the ideal technology for this kind of tissue is microwave ablation, hands down. If you have a solid nodule with solid tissue, not extremely vascular, I think RFA is also an amazing technology. They are both wonderful technologies. So RFA and microwave would be equally efficient there. But when it comes to a cystic tissue, all those little pockets of fluid will slow down your RFA procedure substantially. Whereas with microwave, you can literally blast through the tissue and get the job done much more efficiently. Again, one factor is when you are boiling or you are in an area where you are boiling the fluid in the cyst, with RFA, soon the system misreads it or misreads the impedance of the tissue as very high and lowers the power delivery. And that really slows you down. Whereas with microwave, you can literally blast through the whole thing without worrying about any drop in your power. Heat sink effect is something you will hear about very often. And that is if you are having a nodule that is highly vascular and you apply heat, all those vessels that are in that area, they remove the heat and take it away from the treatment area. So here you are applying the power and the energy, and you are going on and on and on, and you realize nothing is happening. What's going on? And eventually you will see a response. And one way to overcome that, if you are dealing with RFA, would be to just crank up the power substantially. But with microwave, you really don't need to worry about that because there is not nearly as much heat sink effect, and it ablates the tissue highly efficiently. And even those vessels that ideally we want to ablate and cauterize, they get ablated immediately and very efficiently. So, in terms of time saving and efficiency of your work, there is no comparison in hypervascular tissue. And again, in terms of controls and power, the power delivery by Canyon Medical is really very consistent and very steady. And you are constantly getting feedback, and the power delivery is reproducible. Like you know what to count on, what to expect. Whereas with the others, at times you don't know, and you are in for a surprise maybe. And again, uh, as time goes by and as you gain more experience, your learning curve is going to be very steep, and there are so many different aspects of the thyroid nodule ablation that you will learn about. You will read about it first, but also in real time or real life, you really get in there, you do your procedure, and you find out. For example, when I heard about heat sink effect, I'm like, that's just probably a physics theory, and it doesn't apply to what I do. And then have been toxic thyroid nodules that I wanted to ablate with RFA, and I am there and applying the heat on and on and on and on, and really not much is happening unless I really crank up the power. And with microwave, I really didn't have that problem. I would just sail through it and go get it done very efficiently. So at this point, I was planning on showing you some videos of some nodule ablations. For some reason, I could not, for the life of it, just add an image to the slides. So I just want to tell you that in my personal experience, volume reduction is, of course, what we all are interested in at the end if you're dealing with a nodule. And I have had this experience that while volume reduction, both with RFA and microwave across the board, let's say through different types of thyroid nodules, are very comparable. And we're talking about anywhere from 60 to 90% volume reduction, depending on the size of the nodule The larger the nodule, the less volume reduction in general. But again, with larger nodules, volume reduction with microwave, in my opinion, is more efficient, and you see a better VRR, volume reduction ratio. But why? Because with microwave, you are more efficient, it is more powerful. You can cover a larger nodule within the same time frame, and therefore you ablate more. So most studies that have been done comparing RFA and microwave ablation, they just randomly picked some RFA patients, some microwave patients, and looked at the measurements before and after and the percent volume reduction, or the VRR, the ratio, and the conclusion was they are very comparable. Or sometimes, depending on who did the study, it would favor one over the other. But in general, when you look at them, they are very comparable. But I have not seen one study that would look at smaller nodules, RFA versus microwave, and larger nodules, let's say nodules above 50 cc or 40 cc, where it becomes challenging to ablate the whole nodule in one session with RFA. Whereas with microwave, your odds are much better. Now, time limiting factors are also really, some of them are beyond your control. For example, your patient becomes restless halfway through the procedure and cannot lay on his or her back anymore. Or if you keep them waiting too long on the table because you are doing this procedure that is going on for 2 hours, the patient needs to use the bathroom now. And in the middle of your procedure, they start tossing and turning and become a moving target. And when you ask them what's going on, they say, I need to use the bathroom. So you have a choice of pausing, pulling the probe out or the antenna, letting the patient you go use the bathroom and come back and start all over again, or end the procedure right there and then. So because of that factor, again, time is of essence. If you compared two technologies and one of them gets the job done within 30 minutes, the other one needs 45 minutes or longer, I would always go with the faster one that gets the job done. Now, having said that, if I'm dealing with smaller nodules that are very clearly positioned and easily accessible, of course, I choose then between RF and microwave randomly. But if I'm dealing with a larger nodules with a huge volume, I almost always choose microwave over RFA because of the time factor and the fact that the patient, even if I don't get tired, the patient will be exhausted and will become restless. Now, we can also talk in the Q&A section about what to do to maybe relax the patients more or how to pre-medicate them for a procedure. All right. So, in terms of techniques and practical pearls and pitfalls, we have talked about some of them so far. But in terms of preparing your patients, I have prepared these information pages where literally it's an instruction sheet that I email to the patient a few days before their procedure, giving them heads up in terms of how to prepare for the procedure. That includes also a list of certain blood thinners that, if they are on it, when they need to stop it, and they need the fact that they need to coordinate it with their cardiologist or primary care doctor, and also to let them know that ideally they should avoid medications such as ibuprofen, Aleve, aspirin a few days before the procedure if they can. Then also, in terms of pre-medication to prepare them for the procedure, again, this is not a standard approach, and every physician has a different remedy. But in my personal experience, and that's something I learned from Dr. Valcovi in Italy and a few other physicians in Europe, I start the patient in the morning of the procedure on a small, I mean, on a high dose of actually prednisone, and I start them literally on 40 milligrams of prednisone the morning of, the day after the procedure, and this day after. So for 3 days, I give them 40 milligrams of prednisone every morning. This, and in those cases where I didn't do it, I noticed more complaints by the patient, either about the pain or asking for pain medications or about the swelling. Whereas with prednisone on board, they recover pretty fast. So that was one thing in my personal experience that I'm using as a standard approach for everybody, unless the use of prednisone is contraindicated. The second drug I call in a few days before and ask the patient to take before the procedure is alprazolam or Xanax. The purpose of that is to really relax the patient. So I have them, I call in a prescription for zero point 0.5 milligram alprazolam tablets and have the patient take 1 hour before the procedure, two tablets when they arrive to the office at the time of the procedure, and it takes still about 15 to 20 minutes for them to be ready for the procedure. And by the time I walk in, the patient is already sleepy and really um, ready for the procedure. Ideal patient. They just lay down, adjust their position, and most of the time, the minute you start, because of the subtle vibrations of the cooling system, uh, it works like a white noise for the patients, and they just fall asleep. So it's really convenient. And then they respond to you when you talk to them. You want to hear their voice. Definitely ask them, say something. They say something and go back to sleep. But it also makes it more pleasant for them to lay on their back for 40, 45 minutes or as long as you need. So that's one thing. Now, the next thing is the transismic approach. Because of the design of the thyroid, so when we approach the nodule, ideally we should go through the isthmus. I tell many of my younger providers on my team that if they are interested in someday doing thyroid nodule ablation, they better start doing their biopsies also through the isthmus, and also position themselves above the patient's head and use both hands. So if the nodule is in the left lobe, use the left hand. You should use your left hand for holding the probe and right hand for inserting the biopsy needle through the isthmus. And opposite of it would be if the nodule is in the right lobe, you would use your right hand to hold the ultrasound probe and your left hand to insert the needle through the isthmus into the nodule. So practice that transismic um, uh, ambidextrous approach to the nodules so you get really comfortable. And I was really right-handed, and I would position myself everywhere every time I did the biopsy, depending on where it was, either next to the patient or above the patient. But then as I started practicing it, it became so easy to just use left or right hand. Now, the other part is, of course, your ultrasound needs to have a reasonable resolution and quality of images. Very important. The higher the resolution, the better, the easier it is to find your probe and needle. Also, certain adjustments on your ultrasound are essential. You need to be able to focus and adjust the focus of your ultrasound to the height of where the nodule is. You also need to adjust the brightness of the images, as well as also if the nodule is positioned very deep in the back, maybe change the frequency and lower the frequency of your ultrasound to see better in the depth. So those are really important adjustment aspects. So familiarize yourself with your ultrasound machine. Then the next thing is, of course, moving shot technique. Um, if your goal is to really get the whole nodule done in a very timely manner, you really want to use the moving shot technique, meaning you insert the probe all the way to the back of the nodule and start the ablation procedure and just move your needle in a steady manner all the way to the point where you know it is safe. And also, you need to keep in mind microwave, um, the energy covers a few millimeters, like 2 or 3 or 4 millimeters maximum, in front of the tip of your antenna, but most of the power goes backwards. So I can comfortably really advance my antenna all the way, almost all the way close to the capsule of the thyroid and fire and not worry about it going forwards. It goes backwards. But when you pull it back and do your moving shot technique, before you get close to the back capsule of the nodule, you need to stop the power because then you would be damaging the capsule of the thyroid if you go too close to the capsule with the tip of your antenna. Now, power and time again are really important because how much power you put into the nodule over what period of time, it can eventually become a serious issue. If you're dealing with a large nodule and you put huge amounts of power and which translates into heat into the tissue, one concern is that you create a lot of necrotic tissue, and this applies to RFA and microwave. That necrotic tissue usually stays there, and macrophages and their white blood cells move to the area and slowly, gradually remove them. But when it is too much, at times that necrotic tissue can literally break through the tissue in the anterior aspect and lead to one of the things that we are all very concerned about and can be very stressful for the provider, even though it's not life threatening. It looks ugly, but it heals very well and doesn't need any surgical intervention. And that is the so called capsular rupture. That if you look it up, capsular rupture from thyroid nodule ablation, some of the images are really scary. I have had one case where I really got overzealous and wanted to do a little bit more and a little bit more in this gigantic thyroid nodule that was endless. And eventually, the patient went home. Patient did very well. Uh, was happy with how she felt and how she recovered. And around 1 month after the procedure, she messaged me and said, Dr. Falati, I'm having pain and some itching under the skin, and one area is becoming red. The minute she said that, I'm like, oh my God, you are having a capsular rupture, even without her having the capsular rupture yet at that point. I called in prednisone, antibiotics, everything possible to just see if I can calm down the inflammation. Impossible. It penetrated literally through the anterior capsule and tissue and skin and eventually looked like a gigantic pimple. I asked her to fly again back to Utah from Montana, and I used a 16 gauge needle to just drain it, thinking like it is like abscess like material. And I was able to drain some that decompressed it, but then it continued draining and draining for a month and a half. And eventually it shrunk and the skin healed and the patient is fine, but it's just very stressful. Then the other part that I would really encourage you get very, very comfortable with is hydrodissection. You need to really know your hydrodissection, how to hydrodissect in the back of the thyroid, posterior capsule, how to hydrodissect between the nodule and the trachea and that danger triangle, and also in the front. So that's really important. And if you have not done any trainings, during the training, ask your trainers to focus on hydrodissection and show you all the techniques. If you have done your training already, you yourself just keep practicing. Even if you have a nodule that doesn't need hydrodissection because it is in such a safe location, still do the hydrodissection for the sake of practicing it. Pain management, usually, again, the prednisone will do the trick. They can take Tylenol as needed. And in some cases where I know that nodule is large and there is a chance that the patient will have some pain, or based on patient's personality, sometimes you're like, God, she's going to complain about pain. Here's a prescription for tramadol, 50 milligrams, just a few tablets to take as needed. And that would really take care of the pain management issue. And of course, after the procedure, you or your staff or your clinic needs to be accessible and available, especially the first day after the procedure, but also for the first few days. And then ultimately make sure they have an appointment to come back within a month to repeat the ultrasound. If you treated a toxic or autonomous thyroid nodule, to do some labs and to go from there. Now, if you treated a toxic thyroid nodule, don't forget you need to also uh, always switch back and forth between ultrasound and Doppler to see how much of the vessels you have ablated. And ideally, by the time you are done, that whole hypervascular nodule needs to be avascular, no signs of any vascular activity. And ideally, again, you need to find that feeding vessel or supplying vessel that supplies that toxic nodule to ablate it first if you can. So just go back and forth, take your time with the Doppler, find that artery that looks like it's entering your nodule. And the impressive part is when you zap that artery that supplies the blood, suddenly you see the whole hypervascularity of your thyroid nodule is gone. It just shuts off. So that really increases the odds of success because also it becomes less vascular and less heat sink effects with or without microwave or RFA. And your chances of ablating the whole nodule is much higher. Now, in terms of these are more marketing strategies, positioning, adoption, market logic, and stakeholders. I'm going to stay out of that, Todd, if that's okay with you. And ultimately, in terms of where to go with what should be our next step, is first select the right initial case if you're starting these ablative procedures. Um, and again, make sure that um, you really are, first of all, knowledgeable, you're comfortable doing these procedures, and also um, literally work with the patient, with your team. Everybody needs training and knowledge, needs to feel comfortable doing what you're doing. And also, the one important part of training yourself and your team and the patient is you need to train your MAs very well. If you're doing your first case and your MA does not know, or your assistant doesn't know the machine, and you're like, well, we will figure it out. Let's just go in there. And you start, it's gonna really add to your stress and create sometimes chaos. So there are amazing videos that um, Canyon Medical and Mermaid team can provide you with. And those are very educational, but very simple YouTube videos that show you how to start your machine, how to set it up, how to connect the pump, how to do different steps of it to prepare the patient. And that also share that with your team and let your nurses make sure they have watched it. And then before the procedure, go in and kind of set everything up together. So you make sure everything is done right before the first procedure. But then as time goes by, your medical assistant or nurse will be so experienced, and it will be such a blessing to have someone like that where you don't need to worry about the setup of your system. And also always keep a good track of your inventory. So last minute you are not caught by surprise and find, oh my God, I don't have enough antennas, or I don't have any, and I have a few patients scheduled this week. Now, to recruit patients, of course, word of mouth among patients in the community, and also go around and talk to your community and the uh, providers in your community who usually refer to you, and let them know that you have this option now available and you can really help their patients with these procedures. I am going to stop at this point, and again, I think, Todd, do you want to say a few words about this QR code and the purpose of that?
Yeah, yeah. Before we do that, do you mind? There were a couple of questions that came through the chat. Can I throw them your way and maybe take 30,
Absolutely.
45
Yes, please.
seconds to address? So some of
Definitely.
it you alluded to and covered throughout the course of the presentation, but I think there are several that are worth recovering.
Yeah.
Number one, I would imagine early in your practice development, when there wasn't as much information available either in the community or on the internet from an educational standpoint, how did the conversation go with your patients when you were describing an ablative technique versus surgery? How did your
Yeah.
patients react to that?
So the patients were extremely excited about it. So I would start the conversation by telling them what I used to do up until a few years ago before I started doing radio frequency ablation or microwave ablation. And that's their only choice at that point was either basically active surveillance or wait and watch and deal with the symptoms you have, or surgery. And surgery again was a big deal at some point. Now, over time, it has evolved also. And in all fairness to surgeons, I do mention that most of them now are using the robotic surgeries, and the technology is much less invasive, but still, a surgery is a surgery, and there is a downtime, there is some recovery time, there is a potential for some injuries and damage, which is higher in all studies when they looked at ablative therapies versus surgery. Ablative therapies are really superior in that regard. And then I would tell them that so we have now this technology which involves basically you coming in, we do the procedure, and the procedure takes maximum maybe 45 minutes. In case of large nodules, maybe up to an hour. And then we remove the needle. I actually have samples of the needles I have used in the past. So for each one, for radio frequency, for microwave, and for impulse, and I have just cut the cable that attaches to those probes. Just make sure you cover them because I poked myself with one of them and it's painful. But I show them the actual probe and antenna, and I say, okay, and I have a model for the thyroid. I show them how I insert it after numbing the front area with lidocaine, and then insert the probe and start ablating, and this is how it works. I explain the whole thing, and it really lowers their anxiety, and they are very, very excited about it. They said, I want to do it. Do you think my insurance will cover? And some of them, I have over time made a list of insurances and how much their reimbursements have been. And in the past, in the previous few hundred patients. And based on those statistics, I know that certain insurances really pay less than my cost. And those patients I talk to, I tell them honestly that in my experience, your insurance has barely paid anything for it. And unfortunately, we can go the route of insurance, but it is going to be a loss for us. So ideally, if we want to do it, it would be self-pay. And I try to be fair to them in terms of cost and pricing.
Sure, sure.
Uh, and otherwise, your insurance is going to pay, and how much they pay and how much your responsibility is, we can look into it. And my billing team actually, they go to the website of the insurance, find out how much is the deductible, how much are the responsibilities, how much of the deductible has been met by the patient, and call the patient and say, listen, your deductible is $3,000. You have made 2,000 of it, so your responsibility will be $1,000. But we would be happy to bill your insurance. Let's wait and hear from your insurance, and the insurance will tell you how much you have to pay. And the patient agrees with that. We go ahead, sign a financial agreement, a consent form, and move on with the procedure.
Beautiful. Beautiful. Second question, for those that are thinking about transitioning and adopting microwave into their platform, how would you describe a, first couple of cases, nodules that they would want to look for to put themselves in a great position to be successful?
I think if they have done and they have experience with radio frequency ablation and they're just transitioning, that's a different story. Of course, they are already set up. The transition is very easy. You just literally start using microwave, and the nodules that you want to work with to get more experience initially, don't go with smallest nodules that you would ablate. Pick some larger nodules, maybe larger than 5 cc in volume, and ablate them with microwave. And again, follow that rule of low energy when you're near the capsule. And then as you do your moving shot and move away from the capsule, crank up the energy to 30, 35 watts, and then do that. And then when you get close to the back end, again, dial it down to maybe 20 or even 15 to just be very conservative. And then as you gain more experience, you may not even need to adjust it. I put mine at 30 watts and go through the whole nodule, so I don't go up and down.
Yeah,
But to be safe, those would be really good safety measures.
perfect.
But
Last question.
if they have never done any procedures, then of course they need to have the right inventory and be set up for that. They need to, of course, have the equipment, and then literally get started with some easier nodules, more accessible ones closer to the surface. And then as experience is gained, then you can advance.
Perfect. Perfect. And let's close with a question that kind of dovetails with where you started. And that is, what do you think will be needed to broaden U.S. adoption?
I honestly think provider and physician awareness. It is still so shocking to me when I go to one of, I just recently went up north to one of our largest hospitals, literally 40 miles from me, and asked the medical director of internal medicine department to let me do a 10-minute presentation at their medical staff meeting. And I walked into this lecture hall, and they allowed me to just do a quick 10-minute presentation. And I was shocked. The response I got was, oh, everybody was like, oh my God, we didn't even know about it. And many of them were even surgeons or ENT doctors and so on, that who have been so busy just doing their thyroidectomies, they really did not know about it. And also the family practice internal medicine physicians. I think raising awareness at providers level, patients already are catching up much faster through social media. They just go to Instagram and they are following somebody, and that person mentions it, and boom, everybody knows about it. But physicians are really lagging behind, and they depend on guidance and recommendations by American Medical Association or all kinds of organizations, and those organizations have not caught up, are not caught up yet.
Fantastic. Thank you very, very much. As Dr. Falahati alluded to, the QR code that you see on your screen is simply something that you can follow. And if you would like to be contacted for more information, it's a platform that will allow you to put in your pertinent information. Obviously, it's not being shared. It is simply an indication that you would like somebody to reach out to have a discussion from Mermaid and Canyon. So we'll leave that up. But as we close out, I really wanted to thank you for the time taken out of your schedule, Dr. Falahati, to provide us insight, wisdom, education, experience with microwave, RFA, impulse. Um, Everything has its place, and we were pleased that you had an opportunity to share your experience with us. And then on the other side of it, the audience that's out there, we appreciate the time that you've taken out of your personal calendars to learn more about this technology and everything else that's associated with it. We hope you enjoyed the presentation. We hope you learned a little bit. And again, if there's anything that we can do to be of service, to provide information, please snap the QR code and follow that, enter your information. And for reference, this has been recorded and will be made available on the broader social platforms within the next probably 24 hours. But with that, Dr. Falahati, thank you very much. Our
Thank you so
audience,
much,
thank you very
Todd.
much.
Thank you, everybody. And also, please, Todd, if anybody has any questions, they need to talk to me. I would be happy to talk to them by either by phone, and they are more than welcome to have my phone number, or by email. So feel free to reach out, and I would be happy to answer any questions you may have.
Oh, how kind of you. The ability to learn from one of the very best and most experienced. Thank you
Thank you.
all. Have a great rest of your day, evening, morning, wherever you reside. Take
Thank you
care.
so much. Thank you.